Finals SAQ53 Ankle Block. A. List the 5 nerves that can be blocked at the ankle level for foot surgery. This includes the tibial nerve, the saphenous nerve, deep peroneal nerve, superficial peroneal nerve, and sural nerve. Saphenous nerve is a branch of femoral nerve, while other 4 nerves are from the sciatic nerve. B. For each of these nerves, describe the sensory distribution within the foot. The tibial nerve supplies the heel and plantar aspect of the foot. The deep peroneal nerve supplies the first and second toe web space. The superficial peroneal nerve supplies the dorsum of the foot, excluding the first and second toe web space. The saphenous nerve supplies the medial aspect of the foot and ankle. The sural nerve supplies the plantar aspect of the 4th and 5th web space and the 5th toe, and lateral aspect of the foot. C. Give the anatomical landmarks for an ankle block which aid correct placement of local anesthesia for each nerve. The tibial nerve is blocked midway between the medial malleolus and tip of calcaneum. Inject posteriorly to the posterior tibial artery. The deep peroneal nerve, 2 to 3 cm distal to the intermalleolar line, palpate the extensor hallucis longus. Lateral to this is the dorsalis pedis artery. Insert needle just lateral to the DPA. When contact is made with bone, withdraw the needle slightly and inject LA. Landmark for saphenous nerve. Find saphenous vein anterior to medial malleolus. Inject subcutaneously from here, posteriorly as far as the Achilles tendon. Superficial peroneal nerve landmark. Find the tibial edge. Insert needle and direct towards lateral malleolus, raising a subcutaneous wheal. Sural nerve. Infiltrate subcutaneously between the lateral malleolus and Achilles tendon. With ultrasound identification of nerves, usually 2 to 5 mils of LA for each nerve is usually enough. With the landmark technique and subcute infiltration, 5 to 10 mils of LA for each nerve is often required. D. What are the advantages and disadvantages of an ankle block? Advantages includes it provides good post-op analgesia, may avoid GA in high-risk patients, relatively simple technique with low risk of LA toxicity. It produces minimal motor block and can therefore be used for bilateral procedures. Disadvantages: it can be uncomfortable to perform in awake or unsedated patients. Risk of vascular puncture causing hematoma. Saphenous vein is particularly at risk. If tourniquet is to be used, it does not alleviate tourniquet pain. Chairman's report. 65.9% pass rate. Common clinical subjects tend to score well in SAQs and discriminate between strong and weak candidates. Weak candidates had poor anatomical knowledge or failed to list the advantages of this specific block, giving instead the features common to any local anesthetic technique. Poor candidates tended to describe features of blocks at the popliteal level, perhaps due to failing to read the question thoroughly, as ankle level was highlighted. The importance of candidates retaining knowledge of basic science has been highlighted before. Answering the question in table format saves time. Additional information. The SIPS mnemonic for sacral plexus. First, start by listing down the numbers 451, 512, 123, 234, and 34, followed by SIPPS, which stands for superior gluteal nerve and nerve to quadratus femoris, from L4 to S1, inferior gluteal nerve and nerve to obturator internus, from L5 to S2, posterior femoral cutaneous nerve, S1 to S3, pudendal nerve, S2 to S4, and sciatic nerve, from L4 to S3. Next is the I got lunch on Friday mnemonic for lumbar plexus. II stands for iliohypogastric and ilioinguinal nerve. GL stands for genitofemoral nerve and lateral femoral cutaneous nerve of the thigh. O and F stands for obturator nerve and femoral nerve. For iliohypogastric and ilioinguinal nerve, these two branches are from one nerve root, which is L1. For genitofemoral nerve and LFCN, these two branches are from two nerve roots, L1 and L2 for genitofemoral, L2 and L3 for LFCN. For obturator and femoral nerves, these two branches are from 3 nerve roots, L2 to L4. For further information, kindly refer to the video by Dr. Nabil Ibrahim on the lumbar plexus. Thank you.